Morning. Sorry for the technical delays early on. Thanks and welcome back after the holidays. Hope everyone had a great time and got to spend time with family. Today we're back with somebody from Yale itself. It's Dr. Yuan Lu, who's going to talk to us about leveraging digital data and digital strategies for hypertension control and cardiovascular prevention. Dr. Lu was trained in epidemiology and global health and has a particular focus in cardiovascular diseases. She's an assistant professor in the section and an investigator at the Center for Outcomes Research and Evaluation. As her background, she obtained both her ScD and MSc degrees in global health and population at the Harvard School of Public Health. She works at the intersection of CV prevention, health equity, and digital health, and uses implementation science methods to resolve real-world issues. And her long-term goal is to improve care and outcomes through technology-based interventions. The work that she does now began as a K-12 scholar in implementation science, and the project she's focused on is using EHRs of the YNHH health system to identify patients with persistent hypertension and design decision support tools to improve their care. This is in addition to work that she's done collaboratively with colleagues in China and who have led very remarkable studies, including the Million Persons Project, which has health and biomedical resources from 5 million people across China, and the NCD Risk Factor Collaboration, a global analysis of impact of risk factors on global burden of CV diseases. She's authored over 80 peer-reviewed publications, including first author studies in the Lancet, Circulation, and the BMJ, and her work's been widely regarded. So with that, it's a pleasure to have Dr. Lu presenting to us today. Thank you.
Thank you. Thank you, Rohan, for the nice introduction. Good morning, everyone. It's my privilege to be here for the cardiovascular grand round. Every time I join this, I learn a lot. This is my first grand round talk, and it's a great honor to having me here. I would like to take this opportunity to share with you some of my work and the people I collaborated with. And my talk today focuses on leveraging digital data and digital strategy for hypertension control and cardiovascular prevention. Some of you may know me, some of you may don't. So just a little bit about myself. I got my PhD in global health and population from the Harvard Chan School of Public Health, where I got foundational training in global health and transitional epidemiology. I have the opportunity to join the Global Burden of Disease project, where I bring in very different data sources together, trying to quantify the global burden of cardiovascular disease and also quantify the global cardiovascular risk transition. Later, I want to sharpen my skills in CVD risk. Therefore, I came to Yale, did the postdoc with Dr. Harlan Klumholz, focusing training on cardiovascular outcome research. And recently, I just completed the NHRBI K-12 scholar in implementation science. Now, compared to traditional epidemiology, I dive more deep into a new field called digital epidemiology and using very different data sources, mostly from real-world data to understand real-world issue. My research right now focuses on bridging cardiovascular disease prevention, health equity, and digital health, using implementation science method to resolve real-world issue. And my overall goal is to improve the care, outcome, and equity of cardiovascular disease. Here are some of my key research themes. One focus of my research is on learning healthcare system. I bring in different population data sets and real-world data sets to quantify the trends and progress of healthcare in the US over time. I also identify the barriers to risk factor control, designing tools for patient phenotyping, and leveraging real-world data analytics to identify high-risk patients. And finally, design decision support to deliver actionable information to clinicians. And the other focus of my research is on health equity. I've done quite a few work on identify the gaps in healthcare by racial, ethnic subgroup, and by socioeconomic subgroups, and also trying to work with implementation scientists to design digital solutions to address these gaps. All of this is trying to develop precision information and actionable information to inform decision-making by patient, provider, and health systems. So we are entering into the area of digital transformation. The volume of data has been exponentially increased in the last few decades. In 2013, it's estimated the worldwide data is 9 billion terabyte. And then 10 years later, for this year, it's estimated the data volume will increase to 120 billion terabyte. And the data volume is one important component for AI and machine learning to be able to leverage this digital transformation. Despite the growing of data, cardiovascular disease has remained the leading cause of death worldwide. This is a study from the Global Burden of Disease 2019 study. We can see an increasing trend of the absolute number of cardiovascular deaths from 1990 to 2019. And this trend is consistently for both male and female. And here are the top 5 countries with the highest number of cardiovascular deaths in the world. China, because of the large population size, ranking the #1 here, and United States is ranking the #4 here. Yeah, despite cardiovascular disease, they have multiple risk factors, and hypertension has been the leading #1 modifiable risk factors. Again, from the same Global Burden of Disease study, they ran the modifiable risk factors for cardiovascular disease. In both 1990 and 2019, we see high blood pressure is the #1 modifiable risk factors. The number of hypertension people has been growing over time in the world. This is a study from the NCD risk factor collaboration, and I have been fortunate enough to be part of this collaboration. They conduct a pool analysis of 1,201 population representative study from all over the world with 104 million people combining together. And it's showing here the number of people with hypertension has been increasing in the last 3 decades. And if you further looking into the component here, people with controlled hypertension, as colored by green here, is actually a very small proportion of the overall people with hypertension. And the rest of the component include people with undiagnosed hypertension, people who are diagnosed but untreated, people who are treated but not controlled. This trend for the world has been seen consistently, pretty consistently across different continents in the world. And again, controlled hypertension has only been a small fraction of all the people with hypertension. So how about in the US? This is a map from the CDC showing the hypertension prevalence in the last 2 years in adults by counties. In the US, nearly 1 in 2 adults have hypertension. The market is large. Uncontrolled hypertension affects 37 million people using 140 and 90 as the cutoff. If we apply the new definition in the 2017 guideline using 130/80, this number will be even greater. Hypertension contributing to 670,000 deaths per year and 7 million disability adjusted life year per year. Hypertension can lead to life-threatening and organ damage, including stroke, acute infarction, aortic dissection, and heart failure. These conditions are not only associated with high mortality and morbidity, but also associated with high cost. Health system and society are spending 131 billion per year on hypertension-related costs. Despite a great investment, the country has been making little progress in hypertension control. This is a study we published recently using data from the National Health Examination Survey, analyzing data from the last decades. We are showing the trends in the hypertension awareness, treatment, and control. And as you can see on the picture, since 2015 and 16, there has been a declining trends in all awareness, treatment, and control. I want to point out there has been significant racial and ethnic disparity here. Look at the picture on the right-hand side. For the hypertension control, non-Hispanic, Black, and Hispanic individuals have significant lower hypertension control rate than non-Hispanic whites. In the same time, the hospitalization rate for acute hypertension are also increasing. Here is another study we published using the Medicare fee-for-service population. For the definition of hospitalization rate for acute hypertension, we consider all the hospital admissions in the US for Medicare population with a discharge diagnosis for hypertension heart disease, hypertension renal disease, hypertension emergency, hypertension crisis, and hypertension urgency. And then this is the map in 1999. And 20 years later, we can see almost every county in the US has increased hospitalization rate for acute hypertension. In particularly, when we look at disparity in racial ethnic subgroups, African-American actually have the highest hospitalization rate across all the population subgroup by age, sex, race, and dual Medicare status. And we can see also geographical disparity here. The counties with the highest hospitalization rate almost lie into the stroke belt in the South. And because of the slow progress in hypertension control, the US Surgeon General issued a call to action to make hypertension control as a national priority. So from all the slides I presented above, we know the problem. We know a lot of cardiovascular disease, hypertension, and its related health disparity. However, knowing is not enough. We must intervene. The gaps lies in the last mile of implementation. And I think the digital transformation providing an opportunity for us. One way to proceed is to use advances in data science and implementation science to inform and guide how we best implement best practice. To make it clear, the digital transformation of medical data provided an unprecedented opportunity to promote precision cardiovascular prevention and health equity. Data science has the potential to be a powerful facilitator of implementation, empowering individuals and their clinicians with information and tools. Recognizing the importance of integration of data science and implementation science, the National Heart, Lung, and Blood Institute hold a workshop on precision health, and they provide this nice diagram here. It's a little bit complex here, but I will walk you through this. At the bottom of the diagram, you will see an integration of data source, including EHR, claim data, genomic data, social determinant of health, genetic data, behavioral risk, and environmental risk factors. After the integration of this data, they suggest we use data science methods to do individual or community level risk assessment to analyze this risk and identify the high-risk population and high-risk community. And then we can deliver actionable information through clinical decision support or policy support to our end users, including caregivers, patients, clinician providers, communities. And finally, using implementation science to guide how to best deliver this information and scale up the information to diverse population. This is a nice conceptual framework to guide the precision prevention. It includes three important components: data science, quantitative science, and implementation science. More specifically, data science will include ontology, semantics, different data layers, social determinant health factors, and the harmonization of all the data sources from different domains, and its emphasis on diversity, inclusion, and equity. And then quantitative science will highlight using advanced analytics, including computational phenotyping approach, predictive modeling to develop risk scores to identify people at high risk, and AI, machine learning, and other more advanced mathematical model will further facilitate this task. And finally, implementation science methods using novel study design can further help us to test the intervention facility, the feasibility and efficacy, to design intervention to reduce attributable cardiovascular risk, to conduct economic analysis to demonstrate the cost benefits or cost effectiveness of the intervention. And finally, to scale up the intervention to demonstrate the applicability of the intervention in diverse population subgroups. So how can data science and implementation science take us to the last mile? Today, I will give an example of hypertension, but I would like to highlight that the pipeline here is agnostic to hypertension. It could be extended to other chronic conditions such as diabetes, heart failure, chronic kidney disease. So let's start with our ground zero is Mr. Green. Mr. Green is a patient at the Yale New Haven Health System. For patient privacy, Mr. Green is a fake name here. He's an African-American male, 42 years old, presented into Yale New Haven Hospital for heart failure, acute heart failure in 2017. This is a disease that is acquired from uncontrolled hypertension. At that time, his blood pressure is 200 over 120 with ejection fraction of 15%. In looking back, Mr. Green has presented a year earlier for knee pain. At that time, his blood pressure was 201 over 120. He was started on medication and then seen by primary care a week later. But we did not see him again until his presentation for heart failure. On the back end, despite the best effort of the team, we only saw him once in cardiology. He returned 2 years later with a disabling stroke. The outcome for Mr. Green are devastating. The cost to the health system is massive, and the feeling of failure for his physician is massive. Could this have been prevented? I don't know, but we need to understand the root cause. In interaction with Mr. Green, we learned that he's a single dad with 2 young kids. He works 2 full-time jobs. He lives in a community, a zip code where hypertension is rampant, crime rates are high, and life expectancy is less than the national average. And in discussion with Mr. Green, we know that he has no social support. Transportation was an issue. Time off from work was an issue. Most importantly, he has other priorities. Our project tried to emphasize the underlying contextual factors that are likely play a role in Mr. Green's journey and develop them into clinical tools that can support health system and clinicians to be more effective and to better engage patients like Mr. Green in ways related to their experience. Specifically, we are developing decision support tools based on integrated EHR data and predictive analytics to better identify patients at high risk, better phenotype them to understand their characteristics, and deliver real-time information to providers so that the health system can catch people falling through the cracks. We are also designing digital therapeutics, integrating social determinant of health data and patient-reported outcome to fully phenotype patients' experience, to inform visual dashboards, games, and apps for patients, so that we can offer tailored behavior support in the last mile of hypertension control. So for the next few slides, I will go through some of the use case one by one. First, for clinical decision support, we have patient identification, patient phenotyping, and real-time decision support. For patient identification, we are leveraging large data sources from 2 large health systems. I'm fortunate enough to be able to work with Dashpan and Scott Sussman from the Yale New Haven Hospital System, and also with John Brush from the Sentara Health System. So just to give you some background of the 2 health systems, Yale New Haven Health System, as you all know, is the largest health system in Connecticut. It includes 5 hospital delivering network and associated ambulatory clinics. As Yale implemented EPIC in 2013, we have access to EHR data from January 2013 up until December 2021. During this time range, we have 14 million outpatient visits, that include 1.1 million unique patients with at least one outpatient visit in our health system. And Yale system is mostly urban. On the other hand, Sentara Health System involved more of rural area. It is the largest health system in Virginia. It includes 12 hospitals and a large multi-specialty medical group. Sentara implemented EPIC a little bit earlier than Yale, so we have a longer time for the EHR from January 2010 up until December 2021. We have 35,000 35 million outpatient visits with 2.2 unique patients with at least one outpatient visit. This is the characteristic of the patient in the two large health systems. The mean age at Yale is 49 years old compared to 42 years old in the Sentara Health System. Female patients represent 57% in both Yale and Sentara. And then in terms of racial and ethnic subgroups, at Yale we have 70% white, 11% blacks, and then 7% Hispanics in the patient. Sentara have significant higher proportion of African American in their serving area, with about 24% African American, 60% white, and then 9% of Hispanic patient. Let me just give you introduction about the data structure in the electronic health record. In the electronic health record, a patient may have contact with the health system on multiple dates. And then on the same day, they may have multiple visits. And on the same visits, they may have multiple blood pressure measurement. So this is the data structure we have from the EHR. If a patient have multiple blood pressure measurement, we found that the first measurement is oftentimes significantly higher than the rest. So we will drop the first one, take the mean of the rest of the measurement to represent blood pressure value for that particular visit. And if it's only one measurement available in the encounter, there's no choice, then we can just use that single measurement as the blood pressure value for that visit. And if the patient have more than one visit on the same day, we will also take the average to be representative of the blood pressure for that particular day. So using these two powerful data sets, we can look at the trend in prevalence of elevated blood pressure. This is a figure showing the percentage of patients with elevated blood pressure. The x-axis is the time, and the y-axis is the percentage of patients with elevated blood pressure. And then the different colors just represent different blood pressure cut point. For example, the orange color here indicate blood pressure over 130, over 80. And the green color here indicate blood pressure greater than 140 over 90. And the blue color indicate blood pressure greater than 160 over 100. So for here, if a patient have multiple blood pressure measurement within a single year, then we look at the proportion. If 50% of all these blood pressure measurement in a single year for that particular patient is greater than the cutoff, we include that patient in the numerator. So based on these two graphs, we can see almost starting from 2015 or 2016, there has been an increasing trend in the prevalence of elevated blood pressure. And this result is consistent across the two large health systems. When we further look at by racial and ethnic subgroup, we found surprising result. African American has significantly higher proportion of people with elevated blood pressure. And this is the result from Yale. And we see consistent result from Sentara Health System. And this result we saw in the real world data actually consistent with what we see in the National Representative Database from NHANES. Using these two powerful data sets, we have the opportunity to do digital population health surveillance. This is also another paper we published recently. Using a subset of data is a retrospective cohort analysis of EHR data at Yale with 373,000 patients. The eligible patient are those aged 18 to 85 years old and have at least one outpatient visit from January 2013 to October 2017. First, we identify patients with persistent blood pressure elevation. This table shows focus on people with extreme blood pressure value. So the two columns indicate patient with blood pressure greater than 160 over 100, or patient with blood pressure greater than 180 over 120. These are very high blood pressure, much higher than the cutoff that we use to define hypertension. And then the rows of the table shows how many number of blood pressure elevations in this patient. We can see, for example, among patients with blood pressure greater than 160 over 100, nearly 40% of people have at least 2 or more blood pressure elevation. And then the next table just to show how many patients have consecutive blood pressure elevation. To summarize, from this table, we saw a significant proportion of outpatients have markedly elevated blood pressure. Many of them have multiple consecutive elevation despite coming in contact with the health system. Then we also look at patients with blood pressure elevation, but no timely follow-up. Among patients with extreme blood pressure value, about 22 of them have no follow-up at all. 78% of them have some follow-up. And among this 78% of people, only 36% have follow-up visits within 1 month. And this is a time window recommended by the guideline for this extreme level of blood pressure. To summarize, among patients with systolic blood pressure greater than 160 or diastolic blood pressure greater than 100, less than a third had a follow-up visit within 1 month, and less than 20% achieved blood pressure control target in the following 6 months. And recently, we started to look at delay in hypertension diagnosis. Both the Yale data and the Centera data are mapped to the Omap common data model. This is like common data schema, allow us to compare results across different health systems. Here, we use concept ID to define structural diagnosis of hypertension. Structural diagnosis means the actual diagnosis code that the physician put into the chart. Is similar to ICD-9 or ICD-10 code here, but just because of data structure, we use the concept ID. On the other hand, we also define computable hypertension diagnosis. These are patients with blood pressure elevation. We're trying to use the blood pressure to create digital signatures of hypertension. As you can see on this diagram, the red dots indicate a signal for blood pressure elevation, meaning the blood pressure is greater than 140 over 90. If a patient have 2 red dots, meaning 2 blood pressure elevation between at least 30 days apart and less than 2 years, we consider this patient has a computed hypertension diagnosis. This is a useful way to help us to better understand how many people have meet the criteria of hypertension. And for here, we define the second blood pressure elevation as the index date. So among people with computed hypertension diagnosis, we further decompose them into 4 mutually exclusive subgroups. So again, looking at this diagram, the red dot indicate blood pressure elevation signal, and the green dots indicate the actual diagnosis of hypertension that the physician put into the chart. So the first group is patient with no structural diagnosis code. They have blood pressure elevation, but we don't find any structural diagnosis in the year chart. Second group are those with pre-existing diagnosis code. People already have diagnosis of hypertension, but longitudinally follow-up, we found that they still have elevated blood pressure. The third group are those with early diagnosis group, where the structural diagnosis code occur in between the 2 blood pressure elevation signal. And finally, is the eventual diagnosis group. This is the group what we call the delay in hypertension diagnosis. We saw 2 blood pressure elevation signal and the structural diagnosis code occur after the blood pressure elevation. Applying these definitions, we apply to the 2 health systems, and we see the distribution of people across the 2 sites. So we see a significant proportion of these people, 33% and 39% in the two health system have no structured diagnosis code. And then among 15.7% at Yale and 11.6% in Centera have delay in hypertension diagnosis. That is the last group with eventual diagnosis group. And we further look into the last group, those with delay in hypertension diagnosis, to see how long the delay is. We have this chart to show the distribution for delay in hypertension diagnosis in days. At Yale, those smaller group, about 50% of people, we have 389 days delay, almost 1 year delay when the physician put into the diagnosis code in the chart when after they have blood pressure elevation. And the delay in Centera is even longer, is 631 days. The purpose here is not to compare the two health systems, but I want to highlight both last health system identify significant delay and a missed opportunity here for us in terms of hypertension diagnosis. Now we identify patient with high risk, patient with persistent hypertension. The next step is really trying to understand why they have persistent hypertension. This is related to patient phenotyping. Working with Dr. Holland Klumholz, we published a paper to outline a broader framework for persistent hypertension. Persistent hypertension are those with repetitive measure of elevated blood pressure over time. They are a broader group, broader than those with resistant hypertension, and also including those with absence of diagnosis, with inadequate treatment or lifestyle modification, with poor medication adherence, with missed appointment, or other barriers to health care. Because of the multiple causes of persistent hypertension, a broad one-size-fits-all approach cannot address the issue of hypertension. So we're trying to develop an actionable taxonomy of persistent hypertension. This is a paper we put on the preprint and just recently accepted by Sir Outcome. It will be published soon. And this is a qualitative content analysis of clinicians' notes in the EHR of patients with persistent hypertension at Yale. Eligible patients are those 18 to 85 years old, have blood pressure greater than 160 over 100 at 5 or more consecutive outpatient visits between January 2013 to October 2018. We found 1,664 patients met the criteria, of which we randomly select 200 charts for manual chart review. We use a 3-step process to develop the taxonomy. Step 1, we develop a standardized data extraction form for medical chart review. That includes both explicit chart review, looking at both structured and unstructured data fields in the chart, and also implicit chart review, asking the physician to identify what they think after reviewing the chart are the most important contributing factor to persistent hypertension for that particular patient. Step 2, we're using the qualitative data extracted from step 1, further extract concept notes from that. And then step 3, using conventional content analysis, we further develop the taxonomy. This is an iterated process, and we are able to identify 3 content domains of actionable factors contributing to persistent hypertension. So they include non-intensification of pharmacological treatment, non-implementation of prescribed treatment, and non-response to prescribed treatment. This is the definition for each of the one. I will go through them one by one with you. So non-intensification of treatment is defined as antihypertensive medication are not being intensified in the response to persistently severe elevated blood pressure. We further identify 4 subcategories in this group, including provider purview, competing medical priorities, patient preference, and the emphasis of office blood pressure measurement. And then non-implementation of prescribed treatment is defined by a documentation of provider recommended a specified treatment plan, but the treatment plan is not being implemented. There are multiple subcategories in this content domain as well, including issues with obtaining medications, psychosocial barriers, patient misunderstanding, and negative medication experience. Finally, non-response to prescribed treatment is defined as the physician acknowledged persistent hypertension despite documented effort to escalating the treatment and additional pharmacological agent. So there are two subcategories in this group, resistant hypertension and secondary hypertension. And for each of the subcategory, we actually identify the codes from the EHR that could support the subcategory. For example, for patient preview, this is a patient seeing podiatrist. It's documented in the chart saying the patient needs to see his primary MD for hypertension. And then for patient like Mr. Green, there's an issue for obtaining medication. This is a case where the patient, the physician documented in the chart say blood pressure today is in the range of 180 to 190 in systolic and diastolic 130. He has not been taking blood pressure medication at least for a year. Due to the change in the insurance, he has not been able to get the medication. So one thing I want to highlight that all these codes are directly extracted from the chart. That meaning we are based on the real world data from the EHR. Therefore, this taxonomy is pragmatic for clinical use. In the future, we can leverage advanced analytics such as NLP, natural language processing, to automate this taxonomy, analyzing the nodes in the EHR, then automatically classify patients by their contributing factors. That way, we can connect these patients to possible actions. So these are the possible actions that could address persistent hypertension. For example, for provider purview, we can send EHR notification to the primary care provider's office to automatically make an appointment for this patient. For patient with issue with obtaining medication, there may be notification to the provider to screen social risk factors and have EHR smart order sets to make referral to social workers. So let me talk about the decision support tool we can help. We envision a learning healthcare system approach. This is a hub model with a command center in the center. A command center can leverage clinical decision support tool and the integrated EHR data to facilitate screening of populations, to screening risk stratification of individual, further stratify patient by high risk, medium risk, and lower risk, and then monitor the progress over time. In this way, the command center can identify spikes in risk that require face-to-face assessment. And it will provide an opportunity to promote physician adherence to the guideline and care standards. Finally, this is an iterative process. It will learn from experience and iteratively refine the model. Decision support tool has not been a new concept. It has been developed for decades. How has it been doing recently? To understand what's the effect of clinical decision support, I work with Ted Malik from the emergency medicine department here at Yale and Dr. Holland Klumhost from the cardiology section, conduct a state-of-the-art review in clinical decision support in cardiovascular medicine, published in BMJ. From this paper, we know that today the promise of clinical decision support tool delivering scalable and sustained value for patient care in clinical practice has not been realized. We include 77 studies for the qualitative review. Among those, 58 are randomized controlled trial. 31 studies reported common barriers encountered during the clinical decision support tool implementation. Among them, the top 3 are time and resources constraint, lack of capacity with workflow, alert fatigue, distraction from current workflow, and discordance between the local guideline and the clinical decision support recommendation, lack of trust in the clinical decision support recommendation. And then some other reasons, including the complexity of real-world clinical management of cardiovascular disease, the technical problem with CDS and EHR-related issue, and others such as provider buy-in, lack of financial incentive, etc. 23 studies reported common barriers to address this, the common strategies to address this barrier. The top 3 strategies here including integrating CDS into the clinical workflow and the EHR. This is the most important one identified by 13 studies. And then the next one is using audit and feedback from the clinician, the end users of the tool, to iteratively improve the tool. And then the third one is to use precise trigger. For example, using some machine learning model to better estimate the risk to be more precise and reduce alert fatigue. All the other strategies include obtaining provider buy-ins, providing ongoing provider training, and then and others. And then we also summarize 12 recommendations for research and reportings of clinical decision support studies. Because of the time here, I won't go through them one by one, but I think these recommendations are very helpful to guide future CDS study to have a better impact. Once we have the decision support tool in one health system, another challenge is how to scale it to the other one. This is a nice figure from Rohan Kira's paper, looking into, we have the opportunity to work with the Odyssey group. This is the observational health data science and health informatics group. This is outlined a schema. We have 3 hospitals. Each hospital may have different EHR format. How can we scale up the data analytics throughout the hospital? One way is to map this EHR data into a common format. We call Omap common data model. This is one common data model that allows the health system to map their EHR into a common schema. Then one hospital, for example, hospital 1 here would be the development side. Develop the code, analytical code of decision support tool could be easily implemented in the other 2 hospitals. We can leverage this pipeline for quality measurement, quality improvement, and AI-based EHR applications. This is an application of this framework that I use to look at comparative effectiveness of antihypertensive dual combination in real-world setting. I have an opportunity to work with multiple data partners mostly from the Asian Pacific country and some in the US. The objectives of this paper is trying to look at what is the most commonly used dual combination of antihypertensive drug in different countries. We are including 11 EHR databases that cover over 118 million patients across 8 countries and regions between 2000 and 2019. This is a table showing the use of drug duration. It's a very dense table, but I just want to highlight the main finding is that we identified 12 dual combination drug classes that are commonly used, and there are large variants across country and demographic groups. An example would be, look at this diuretic. It's used 17 or 18% in the US database. However, the percentage is much, much lower among Asian countries like Korea and Singapore, China and Taiwan, and also lower in France. On the other hand, calcium channel blocker is more commonly used in Asian Pacific country, but it's less commonly used in the US. There's some research showing calcium channel blocker may have smaller side effect in Asian population, and also the insurance in most Asian countries like China will cover calcium channel blocker. It's much cheaper than ACE inhibitor or thiazide diuretic. So that explains some of the reason for that. This highlighted diversity of treatment prescribed in clinical practice, and it also highlight future research need to further investigate which combinations are associated with the best outcome for which patients. Then later on, finally, I'm going to just quickly walk through to the digital therapeutics. This is the work we are currently start doing and we plan to do in the near future. We don't have end product for now, but would like to give you some example for it. First is the integration of social determinant health and patient-reported outcome. We are trying to use geocoding information. This is patient's address, patient's zip code, patient's census tract to map them to accessible social determinant health. As you know, CDC, they publish social determinant health and social deprivation index at the census tract level. By using geocoding, we are able to link the EHR data or Medicare data with social determinant health to better phenotype patients. This is a paper published by Dr. Khurram Nasser from the Houston Methodist Group. He used to be a colleague at Yale, and I work with him very closely. So on figure 1, this is showing the overall social variability index by US county. And on figure B is the premature cardiovascular mortality. We can see there's a high correlation here. The counties with higher social deprivation index also have higher cardiovascular mortality. And we are leveraging the same pipeline here to trying to merge the EHR data at Yale with the social variability index. There's also other opportunity to integrate with patient-reported outcome, wearables, and other patient data. This is a Yale Listen study led by Professor Akiko Asaki and also Dr. Holland Klumhouse. I'm fortunate enough to join this study. And then the overall goal is trying to understand long COVID, post-vaccine adverse events, and corresponding immune response. It's not related to hypertension, but the pipeline we learned here could be extended to hypertension, diabetes, and other chronic disease. In terms of workflow, people join Kindred Digital Health Research Community, where they link their data, respond to survey, share their experience, and access to experts. They provided consent to join Kindred. This would enable us their data to be part of the study. And we selected some of the members to have biospecimen collection for immune signatures. Along the way, we will share the study result with the participant so that they can know what their data used for. This is a diagram showing we're using the Hugo digital platform as a hub to integrate multiple data sources. The Hugo platform providing a simple integration for any third-party customers. It can connect providers, pharmacies, payers, and device, and even more, and provide secure credential storage for data and management. And it's pretty simple for patients to use. Finally, I just want to quickly touch on dashboard, games, apps, and tailored behavior support. So I'm working with Erica Spas in the digital hypertension program, and we are collaborating with Feline Ling from the Yale Center for Health and Learning Games. They were trying to use gamification to provide digital games, digital support for patients. This is an example developed by their lab, using digital games to prevent smoking in adolescents. In this way, they are making the intervention fun for the end user. It's no longer the burden for the end user, but making it more fun so that we can increase adherence to the intervention. All these work are honed in the Center for Outcomes Research and Evaluation. We are a leading outcome research center with a computational data science center and is partnered with patients. This is the ecosystem for our collaboration. Locally, we are collaborating with Yale New Haven community, the Yale Center for Clinical Investigation, Yale New Haven Health, and Yale University. Externally, we are collaborating with academic medical centers, health systems, and foundations. And we are also paying attention to the broad environment, including regulation agencies, payers, and industry. These are just some of the collaborators we have been working in the past. In the end, I just want to summarize our goal is to leverage the digital transformation to produce precise, actionable insight and to support decisions. To empower individuals and communities, to produce performance assays that are real-time and meaningful. Our research outcome will be pragmatic, scalable, and valid insights and tools that can help people health systems, and communities to make informed decisions to better propel better health and health equity. Finally, I would just want to highlight, want to thank so many people here, including my faculty mentorship committee, collaborators, both from Yale and outside Yale, for postdocs and students. This is really a team effort. Without their collaboration and support, there's no way we can make any progress as we show in the slide. So thank you so much for your attention. It's my great honor here, and feel free to ask me if you have any questions.
Now we'll just take some questions from the audience. Any questions here? Then we have some Zoom questions.
I can just ask a quick question. So thank you, Yuan. That was a really nice summary of this book. I think I have two questions. One is related to the future of hypertension and changes national over the last 1 year. And it just seems to me that those systemic change is just as much as found that data or systemic contributors change. And you forward, age and population of the other factors. Very rapid, right? That's question one. The second question is, I think these tools are differentiated for to fight the way of the future. But I really focus on trying to understand how to build a workforce tomorrow without that. These tools are easy, right? So you speak to what for you to push forward concept.
That's a great question. Thank you, Dr. Valeska. For the first question regarding the acute hypertension hospitalization rate, I think you raised a great point. We did look at a characteristic of patient in 1999 and 2019, and we found exactly as you mentioned, many of these comorbidities like diabetes, chronic kidney disease are increasing over time, and this may be contributing to the increasing trends of hospitalization rates. We haven't got into further to further decompose it, but I think this patient, they admitted to the hospital. It has to be some, I think it's very severe patient. They usually, not only they have blood pressure elevation, usually they will have some symptoms or some end organ damage so that they can admit it to the hospital. But yeah, we suspect that the increase in chronic comorbidities over time will be a major contributor to that. Yeah. And then the second question regarding the workforce, I think that's also a very important point. We need to build the next generation that can understand both data science and implementation science. We are fortunate enough to have you and Dr. Spiegelman to be the leader of the T32 program to training postdocs, fellows in implementation science. At Yale, we also have the K-12 Scholar Program, and I'm fortunate enough to be part of, and I learned so much from it. This is entirely a new field for me. And then I think also important for the clinician, most of them may not have the background in data analytics, so getting more exposed to those, like at CORE, we are holding some seminars, workshops, and also we are regularly recruiting like residents, fellows, clinical fellows to do part-time research work at CORE, so that help them to develop the skill sets in data analytics and data science. It would be important in the next generation to know not just one field in medical area, but also combine the knowledge from implementation science and data science to better understand.
I mean, I think the research is critical. The implementation gap, I think, is dependent on a clinical workforce that can take that research and put it in practice, which is the real failing of our system. Some organizations, global regions focus on community health workers and so-called CHOOS, and we don't have that tradition here in the U.S. That it would be very interesting to understand how we implement that in Haven as trial and in the future. I think that's, unfortunately, I think that's the missing step that clinical information work. We have, as you said in your talk, we have to move beyond research implementation, right?
Yeah. in those settings, maybe it would be important to have a close collaboration with clinician. So for example, for me, I'm not a clinician, but the tools I developed, the end users are clinicians. So I need to work very closely with clinicians to actually analyze the data, to understand like whether the result actually makes sense clinically, and also develop the tools that are useful for them, because in the end, it will be used by clinicians. Yeah, so I think it would be important to in that close collaboration mode.
Very important topic. I really enjoyed your talk and all the efforts that here from different people. So one thing, maybe I missed it from your talk, is that the mode of measurement of the blood pressure can also affect the results. So for example, in my clinic, I mean, the ambulatory measurement of blood pressure should be carefully done. Often patients come to my room and they have a high blood pressure, and then they said, well, I never had this blood pressure. And they come up with the very high blood pressures that measured by the nurses outside my room. And then when I can repeat them, they actually are lower, in fact. And, that's let's go to the computer. If I'm busy, I'm not going to be always able to do that. But this is actually mode of this. The other thing is actually was very important thing you touch base on, and that's a comparison between antihypertensives. And I see there's a lack of knowledge, for example, general. For example, losartan is considered a once-a-day drug. In fact, actually, it doesn't last that long. And, I prescribe it for twice a day. I get a call from the pharmacy that is wrong. So there is a lot of important work to be done to see actually really what is the effect size of these medications and compare them. Yeah.
Yes, definitely. Good point. I think we are only scratching the surface right now. It's really a big, like just an ice tip. It's really a big part underneath this. Regarding the modes of hypertension, I think here we have a category called the emphasis of office blood pressure measurement. Yeah, let's go back to the quotes. Yeah, so the quote here, if you look at table 2 at the very bottom, these are the patients what we consider as white coat hypertension. They have routine home blood pressure monitoring that shows excellent control, but when they come to the clinic, the blood pressure is high. So I think that for this one, the intervention would be one possible intervention. It's not the only intervention, is to have EHR smart order set that assist physician to order home blood pressure monitoring. And I know Erica Spas in her clinic, she's using a Bluetooth blood pressure cuff that can automatically sync the data from the home blood pressure monitor with the EHR data. That way, we can, when the patient comes in, the clinician can see, oh, what is measured at home and what is measured in the clinic to inform better decision. We just started, I think it's a small sample, like 100 patients something, but it's showing great promise. Hopefully it could be extended to a broader community.
Kind of to add on to that, because I know Erica was here, but to give her a plug, she has also developed this pharmacy-based clinician collaboration. So it deals with this workforce, because obviously this is such a huge problem that I don't think physicians themselves can deal with it enough. But it really has just been a pilot program in a few areas, one of which is in the fellows clinic to deal with this, to have the pharmacy run and linked in with this home blood pressure monitoring. It's, at least with our patient population, it's been a game changer in terms of how much the touches that the patients can have to deal with their hypertension. And I don't know how much it is, but then it would be the feedback to be able to get all that information back to people like yourself to really evaluate these programs to see how they're working and how they can be improved. I think that'd be very important as well.
All great points. Thank you. I think leverage the non-physician providers like pharmacies, community health workers, or nurse practitioners would be a major part here, because the clinicians are so overwhelming. They only have 50 minutes in the visits. We found that in reality, it's not feasible to add additional tasks on the clinician's busy. busy schedule, it's better to leverage like pharmacists, nurse practitioners to better do some of this like repeated blood pressure measurement, documented in the chart, something like that, to better help to do this task. Yeah.
Maybe one comment, I know there was one chat, and we're past time, but I think the slide actually relates to Dr. Matt Bird, who asked a question.
Yeah.
That maybe you can follow up with him.
Yes.
Around how we address non-adherence, how we measure non-adherence to medication or resistance to medication initiation as part of a variable monitor in this work. And I think I will copy this question, maybe follow up.
Yeah, thank you. Yeah. Shall I answer briefly here?
Yeah,
Yeah.
sure.
Yeah, so measuring adherence is definitely very challenging. It's very hard. Most direct way is to ask patient, but most of the time we don't have this data. One proxy for that is using the pharmacy refill data. Like at Yale, we have shared script. So we can use shared script data to look at pharmacy refill. How many prescription has been refilled by the pharmacy? If the prescription has not been refilled, this has been used in research as an indicator for non-adherence for medication. So I think using this large data set, we can sort of provide some hints to adherence of medication. And during the encounters, it will prompt the providers to have more conversation with the patient. That is a very short answer. Yeah.
Thank you so much.
Thank you.
This is great.